Listen carefully. These are not your basic maternity questions. These are ICU-level obstetric emergencies, the kind that test real clinical judgment, prioritization, and life-saving decision-making. If you're preparing for NCLEX 2026, you must think like this. What will kill the mother first? What will compromise the fetus fastest? What requires immediate escalation? Pause the video for each question. Think like the nurse in charge. Then I'll break it down step by step. Let's begin. Question 1. A nurse is assessing a client at 32 weeks gestation who reports a severe headache, blurred vision, and epigastric pain. What is the nurse's priority action? A. Reassess in 1 hour. B. Check blood pressure immediately. C. Encourage oral fluids. D. Document findings in the chart. Answer: B. Check blood pressure immediately. Rationale: these findings suggest severe preeclampsia with possible cerebral and hepatic involvement. Immediate blood pressure assessment determines severity and risk for seizure or stroke. Reassessment later, A, delays intervention. Encouraging fluids, C, does not address hypertensive crisis and may worsen edema. Documentation, D, follows urgent assessment and stabilization. Question 2. A postpartum client has a boggy uterus and heavy lochia 1 hour after delivery. What is the nurse's first intervention? A. Administer oxytocin. B. Massage the fundus. C. Call the provider. D. Assess vital signs. Answer: B. Massage the fundus. Rationale: a boggy uterus indicates uterine atony, the leading cause of postpartum hemorrhage. Fundal massage is the immediate nursing action to stimulate contraction. Oxytocin, A, may be required, but massage is first line and immediate. Calling the provider, C, occurs if bleeding persists. Vital signs, D, are important, but controlling hemorrhage is priority. Question 3. A client receiving magnesium sulfate for preeclampsia has respirations of 10 per minute and absent deep tendon reflexes. What should the nurse do next? A. Increase infusion rate. B. Continue monitoring. C. Administer calcium gluconate. D. Place in Trendelenburg position. Answer: C. Administer calcium gluconate. Rationale: respiratory depression and absent deep tendon reflexes indicate magnesium toxicity. Calcium gluconate is the antidote and must be given immediately. Increasing infusion, A, worsens toxicity. Monitoring, B, delays life-saving intervention. Trendelenburg, D, does not reverse toxicity. Airway and antidote administration are priority. Question 4. The nurse is interpreting a fetal heart rate tracing showing recurrent late decelerations with minimal variability. What is the most appropriate nursing action? A. Reposition the client to left lateral. B. Increase oxytocin infusion. C. Encourage pushing efforts. D. Document as expected finding. Answer: A. Reposition the client to left lateral. Rationale: late decelerations with minimal variability indicate uteroplacental insufficiency and possible fetal hypoxia. Repositioning improves placental perfusion. Increasing oxytocin, B, worsens uterine stress. Encouraging pushing, C, increases oxygen demand. Documentation, D, is inappropriate because this is non-reassuring and requires intervention. Question 5. A client at 34 weeks with complete placenta previa presents with painless, bright red bleeding. Fetal heart rate is 150 per minute with moderate variability. Maternal BP is 98/60 millimeters mercury. Pulse 118 per minute. What is the nurse's priority action? A. Prepare for immediate digital vaginal examination. B. Initiate 2 large-bore IV lines and prepare for possible transfusion. C. Administer oxytocin to control bleeding. D. Perform fundal massage. Answer B. Initiate 2 large bore IV lines and prepare for possible transfusion. Rationale. This client shows signs of hypovolemia, tachycardia, low BP, with known placenta previa. The priority is maternal stabilization with rapid IV access for fluids and blood products. A digital exam, A, is contraindicated because it can cause catastrophic hemorrhage. Oxytocin, C, is ineffective since bleeding is from placental implantation, not uterine atony. Fundal massage, D, is inappropriate and may worsen bleeding. Clinical judgment prioritizes maternal stability and early recognition of catastrophic complications. Question 6. Select all that apply. A client with severe preeclampsia at 30 weeks is receiving magnesium sulfate and betamethasone. Which findings require immediate intervention? A. Urine output of 20 milliliters per hour. B. Serum magnesium level of 9 milligrams per deciliter. C. Deep tendon reflexes 1+. D. Respiratory rate of 11 per minute. Answer A. Urine output of 20 milliliters per hour. B. Serum magnesium level of 9 milligrams per deciliter. D. Respiratory rate of 11 per minute. Rationale. Urine output less than 30 milliliters per hour indicates renal compromise and risk of magnesium accumulation. A magnesium level of 9 milligrams per deciliter is above therapeutic range of 4 to 7 milligrams per deciliter and signals toxicity. Respiratory depression 11 per minute suggests respiratory depression. These require immediate action, possible discontinuation, and antidote readiness. Reflexes 1+, C, are slightly diminished but not absent. Absent reflexes would be more concerning. Clinical judgment integrates lab data, assessment findings, and medication effects. Question 7. True or false? In a client with suspected uterine rupture during a trial of labor after cesarean, TOLAC, reassuring fetal heart tones eliminate the need for emergency intervention. A. True. B. False. Answer B. False. Rationale. Uterine rupture is a life-threatening emergency. Even if fetal heart tones appear temporarily reassuring, maternal signs, sudden abdominal pain, loss of station, abnormal contractions, hypotension, require immediate surgical intervention. Waiting for fetal deterioration delays life-saving care. Clinical judgment prioritizes maternal stability and early recognition of catastrophic complications. Question 8. Yes or no? Should RHD immune globulin be administered within 72 hours after delivery if the newborn is Rh positive and the mother is Rh negative? A. Yes. B. No. Answer A. Yes. Rationale. Administration within 72 hours prevents maternal sensitization and protects future pregnancies from hemolytic disease. Failure to administer increases risk of alloimmunization and fetal anemia in subsequent pregnancies. Question 9. A postpartum day 2 client reports sudden shortness of breath, chest pain, and anxiety. Vital signs: BP 88/54 millimeters mercury, pulse 126 per minute, RR 28 per minute, and O2 saturation 89%. What is the nurse's priority action? A. Encourage deep breathing exercises. B. Elevate the legs and apply heat. C. Apply oxygen and activate rapid response. D. Obtain Homan sign. Answer C. Apply oxygen and activate rapid response. Rationale. These findings strongly suggest pulmonary embolism, a leading cause of maternal mortality. Immediate oxygenation and emergency response activation are priority to prevent cardiovascular collapse. Encouraging deep breathing, A, delays life-saving care. Elevating legs and heat, B, are inappropriate and may worsen clot migration. Homan sign, D, is unreliable and wastes critical time. Clinical judgment requires rapid recognition of life-threatening deterioration and emergency escalation. Question 10. Select all that apply. A nurse is discharging a client after a cesarean birth. Which instructions are appropriate? A. Report redness or drainage from incision. B. Lift objects heavier than the newborn after 1 week. C. Avoid driving until pain-free and off narcotics. D. Seek care for foul-smelling lochia. Answer: A. Report redness or drainage from incision. C. Avoid driving until pain-free and off narcotics. D. Seek care for foul-smelling lochia. Rationale: incision infection signs must be reported. Driving while on narcotics is unsafe. Foul-smelling lochia suggests infection. Lifting heavy objects after 1 week increases risk of wound dehiscence and is unsafe. Question 11. A client at 28 weeks gestation reports decreased fetal movement for the past 24 hours. What is the nurse's priority action? A. Schedule a routine visit next week. B. Perform a non-stress test. C. Encourage increased fluid intake. D. Teach kick counts for later use. Answer: B. Perform a non-stress test. Rationale: decreased fetal movement may indicate fetal hypoxia or placental insufficiency. Immediate fetal assessment via non-stress test evaluates fetal heart rate reactivity. Delaying evaluation, A, risks fetal compromise. Fluids, C, are not priority. Kick count teaching, D, is preventative but not appropriate when decreased movement is already present. Question 12. A laboring client receiving oxytocin develops contractions every 1 minute, lasting 90 seconds, with fetal bradycardia. What is the nurse's first action? A. Continue infusion and monitor. B. Stop oxytocin infusion. C. Increase IV fluids only. D. Prepare for discharge. Answer: B. Stop oxytocin infusion. Rationale: uterine tachysystole with fetal bradycardia indicates uteroplacental insufficiency. Immediate discontinuation of oxytocin removes the cause. Fluids may follow, but stopping oxytocin is first priority. Continuing, A, worsens hypoxia. Question 13. SADA. A postpartum client is at risk for hemorrhage. Which risk factors should the nurse recognize? A, prolonged labor. B, multiple gestation. C, magnesium sulfate therapy. D, history of postpartum hemorrhage. Answer: A, prolonged labor. B, multiple gestation. C, magnesium sulfate therapy. D, history of postpartum hemorrhage. Rationale: all increase risk of uterine atony. Overdistension, uterine fatigue, smooth muscle relaxation, and prior history elevate recurrence risk. Question 14. A client with gestational hypertension develops tonic-clonic seizures. What is the nurse's immediate priority? A, insert an oral airway. B, turn client to side and protect airway. C, restrain extremities. D, call family. Answer: B, turn client to side and protect airway. Rationale: during eclamptic seizure, airway protection and aspiration prevention are priority. Oral airway insertion risks trauma. Restraints increase injury risk. Clinical judgment prioritizes metabolic stabilization over bonding. Question 15. A preterm client with premature rupture of membranes at 36 weeks has fever and fetal tachycardia. What complication is suspected? A, placenta previa. B, chorioamnionitis. C, hyperemesis gravidarum. D, preeclampsia. Answer: B, chorioamnionitis. Rationale: maternal fever plus fetal tachycardia after membrane rupture indicates intrauterine infection requiring antibiotics and likely delivery. Question 16. True or false? A postpartum day 1 client has a firm uterus deviated to the right with moderate lochia rubra. This finding is normal and requires no intervention. A. True. B. False. Answer: B. False. Rationale: although the uterus is firm, deviation to the right suggests bladder distension, which prevents optimal uterine contraction and increases hemorrhage risk. The nurse must assess bladder fullness and assists with voiding. Clinical judgment requires recognizing that firm alone is insufficient. Position matters. Ignoring deviation may lead to secondary atony. Question 17. A client receiving epidural anesthesia develops hypotension and fetal late decelerations. What is the priority intervention? A. Reposition to left lateral and increase IV fluids. B. Stop epidural permanently. C. Increase IV fluids only. D. Apply fundal pressure. Answer: A. Reposition to left lateral and increase IV fluids. Rationale: epidural-induced hypotension decreases placental perfusion. Restoring maternal circulation improves fetal oxygenation. Question 18. SATA. A newborn of a mother with poorly controlled gestational diabetes exhibits jitteriness and tachypnea at 1 hour of life. Which nursing actions are a priority? A. Check blood glucose immediately. B. Initiate early feeding. C. Place under radiant warmer. D. Delay assessment to allow bonding. Answer: A. Check blood glucose immediately. B. Initiate early feeding. C. Place under radiant warmer. Rationale: poorly controlled diabetes causes fetal hyperinsulinemia, leading to neonatal hypoglycemia. Jitteriness and tachypnea are classic signs. Immediate glucose assessment confirms diagnosis. Early feeding prevents neurologic injury. Thermal regulation reduces glucose consumption. Delaying assessment, D, risks seizures and brain injury. Clinical judgment prioritizes metabolic stabilization over bonding. Question 19. A 39-week client presents with sudden severe abdominal pain, board-like uterus, hypotension, and fetal bradycardia. Vaginal bleeding is minimal. What is the nurse's priority action? A. Prepare for emergency cesarean birth. B. Perform vaginal examination. C. Administer oxytocin. D. Encourage pushing. Answer: A. Prepare for emergency cesarean birth. Rationale: findings indicate concealed abruptio placentae with fetal compromise. Minimal bleeding does not rule out severe hemorrhage. Immediate surgical delivery is required to prevent maternal shock and fetal death. Vaginal exam delays care. Oxytocin worsens separation. Pushing is contraindicated. Clinical judgment recognizes concealed hemorrhage despite limited external bleeding. Question 20. A postpartum client reports severe perineal pain and rectal pressure. What should the nurse suspect? A. Normal healing. B. Hematoma formation. C. Urinary retention. D. Infection. Answer: B. Hematoma formation. Rationale: disproportionate pain suggests concealed hematoma requiring urgent evaluation. Question 21. Yes, no. Should a nurse continue frequent fundal massage every 5 minutes after the uterus becomes firm in a stable postpartum client? A. Yes. B. No. Answer: B. No. Rationale: excessive massage of an already firm uterus can cause relaxation and increase bleeding. Ongoing assessment is required, but overstimulation may lead to atony. Clinical judgment differentiates between therapeutic massage for atony and harmful overuse once tone is restored. Question 22. A prolapsed umbilical cord is visible during labor. What is the immediate action? A. Push cord back in. B. Elevate presenting part and apply saline gauze. C. Encourage ambulation. D. Delay intervention. Answer: B. Elevate presenting part and apply saline gauze. Rationale: relieving cord compression maintains fetal oxygenation until emergency delivery. Question 23. SATA. A postpartum day 3 client reports new symptoms. Which findings require immediate emergency evaluation? A. Severe unilateral calf pain with swelling. B. Sudden onset shortness of breath. C. Saturating one pad in 45 minutes. D. Mild mood swings. Answer: A. Severe unilateral calf pain with swelling. B. Sudden onset shortness of breath. C. Saturating one pad in under an hour. Rationale: calf pain suggests deep vein thrombosis. Shortness of breath indicates possible pulmonary embolism. Saturating a pad in under an hour signals hemorrhage. These are life-threatening complications requiring emergency care. Mild mood swings are consistent with baby blues and not emergent. Clinical judgment prioritizes thromboembolism and hemorrhage as leading causes of maternal mortality. Question 24. A client in active labor feels urged to push at 6 centimeters dilation. What is the nurse's best response? A. Encourage pushing. B. Assess dilation immediately. C. Administer sedative. D. Increase oxytocin. Answer: B. Assess dilation immediately. Rationale: urge to push may indicate rapid cervical change. Assessment prevents cervical edema from premature pushing. Question 25. A postpartum client reports hopelessness and inability to care for newborn. What is the priority action? A. Reassure as normal. B. Notify provider immediately. C. Delay care. D. Encourage rest only. Answer: B. Notify provider immediately. Rationale: symptoms indicate possible postpartum depression requiring urgent evaluation to protect maternal and newborn safety. Question 26. A 30-week client with severe preeclampsia reports worsening right upper quadrant pain, BP 168/110 millimeters mercury, platelets 82,000 per millimeter cubed, AST 220 UL, LDH elevated. The fetal tracing shows minimal variability. What is the nurse's priority action? A. Administer acetaminophen for pain. B. Prepare for immediate delivery. C. Reassess labs in 6 hours. D. Increase magnesium sulfate rate. Answer: B. Prepare for immediate delivery. Rationale: this client meets criteria for HELP syndrome, hemolysis, elevated liver enzymes, low platelets, with severe features and fetal compromise, minimal variability. Maternal risk includes liver rupture, DIC, stroke. The only definitive treatment is delivery. Pain medication, A, masks worsening pathology. Waiting, C, risks catastrophic rupture. Increasing magnesium, D, does not treat underlying disease and may worsen toxicity. Clinical judgment prioritizes maternal stabilization and delivery over gestational age concerns. Question 27. SATA. A laboring client at 8 centimeters dilation develops recurrent deep variable decelerations to 60 bpm lasting 70 seconds, despite repositioning. Which actions should the nurse anticipate? A. Discontinue oxytocin. B. Administer IV fluid bolus. C. Prepare for amnio infusion. D. Prepare for emergent cesarean birth if unresolved. Answer: A. Discontinue oxytocin. B. Administer IV fluid bolus. C. Prepare for amnio infusion. D. Prepare for emergent cesarean birth if unresolved. Rationale: deep recurrent variables indicate significant cord compression. Oxytocin reduces uterine stress. Fluid bolus improves perfusion. Amnio infusion alleviates compression. If persistent, operative delivery is required. Clinical judgment escalates stepwise but prepares for emergency intervention simultaneously. Question 28. A client with insulin-controlled gestational diabetes in labor has glucose 58 milligrams per deciliter and reports shakiness. What is the nurse's priority? A. Administer rapid-acting insulin. B. Provide IV dextrose. C. Encourage ambulation. D. Delay treatment until after delivery. Answer: B. Provide IV dextrose. Rationale: Maternal hypoglycemia threatens both mother and fetus. Immediate correction with IV dextrose prevents seizure and fetal compromise. Insulin, A, worsens hypoglycemia. Delay, D, is unsafe. Clinical judgment prioritizes maternal stabilization first. Question 29. True or false? A Category 2 fetal heart tracing with moderate variability and recurrent variable decelerations requires immediate cesarean birth. A. True. B. False. Answer: B. False. Rationale: Category 2 is indeterminate. Presence of moderate variability suggests preserved fetal oxygenation. Intrauterine resuscitation is attempted before operative delivery. Immediate cesarean is reserved for persistent Category 3 tracings. Question 30. A postpartum client 12 hours after vaginal birth becomes tachycardic, HRR 124, hypotensive, BP 86/48, pale and breathless. Fundus is firm and midline with minimal lochia. What is the nurse's priority action? A. Massage uterus vigorously. B. Suspect concealed hemorrhage and activate emergency response. C. Encourage oral fluids. D. Document findings. Answer: B. Suspect concealed hemorrhage and activate emergency response. Rationale: Firm uterus with shock signs suggests concealed bleeding, e.g., vaginal hematoma, uterine rupture. Minimal lochia does not rule out hemorrhage. Immediate escalation and rapid transfusion prep are required. Massage is ineffective when uterus is firm. Clinical judgment recognizes shock despite normal fundal tone. Question 31. During labor induction, a client suddenly reports sharp abdominal pain and cessation of contractions. Fetal heart rate drops to 70 bpm. What is the nurse's immediate priority? A. Increase oxytocin. B. Reposition and continue monitoring. C. Suspect uterine rupture and prepare for emergency surgery. D. Perform vaginal exam only. Answer: C. Suspect uterine rupture and prepare for emergency surgery. Rationale: Sudden pain, loss of contractions, and fetal bradycardia indicate uterine rupture. This is a catastrophic emergency requiring immediate surgical intervention. Delay risks maternal hemorrhage and fetal death. Question 32. SATA. A 35-week client with preeclampsia develops sudden dyspnea and crackles. Which findings indicate pulmonary edema? A. Oxygen saturation 88%. B. Pink frothy sputum. C. Bounding pulses. D. Anxiety and air hunger. Answer: A. Oxygen saturation 88%. B. Pink frothy sputum. D. Anxiety and air hunger. Rationale: Pulmonary edema in preeclampsia results from capillary leak and fluid overload. Hypoxia, frothy sputum, and air hunger are classic signs. Bounding pulses are not specific. Immediate oxygen and diuretics are required. Question 33. A client receiving magnesium sulfate has serum level 10 milligrams per deciliter and respiratory rate 8 per minute. What is the nurse's immediate action? A. Stop infusion and administer calcium gluconate. B. Continue infusion and reassess. C. Encourage coughing exercises. D. Place in Trendelenburg position. Answer: A. Stop infusion and administer calcium gluconate. Rationale: Level above therapeutic range, 4 to 7 milligrams per deciliter, with respiratory depression indicates toxicity. Antidote must be given immediately. Delay can lead to cardiac arrest. Question 32. Yes or no? Should delayed cord clamping be performed in a newborn requiring immediate resuscitation with apnea and poor tone? Yes. No. Answer: No. Rationale: While delayed clamping benefits stable newborns, immediate resuscitation takes priority in compromised infants. Airway and ventilation override routine practice. Question 35. A postpartum client with severe headache, visual disturbances, and BP 170 over 112 millimeters mercury 3 days after discharge presents to the ED. What is the priority intervention? A. Administer magnesium sulfate. B. Provide acetaminophen only. C. Discharge home. D. Encourage hydration. Answer: A. Administer magnesium sulfate. Rationale: this is postpartum preeclampsia with severe features. Risk of seizure remains up to weeks postpartum. Magnesium prevents eclampsia. Delay risks stroke. Question 36. SATA. A newborn of a diabetic mother is lethargic with glucose 32 milligrams per deciliter. Which actions are priority? A. Initiate IV glucose. B. Encourage breastfeeding immediately. C. Place under radiant warmer. D. Monitor for seizures. Answer: A. Initiate IV glucose. C. Place under radiant warmer. D. Monitor for seizures. Rationale: severe hypoglycemia, less than 40 milligrams per deciliter, requires IV correction. Thermal stability reduces glucose use. Seizure monitoring is critical. Breastfeeding alone is insufficient for severe hypoglycemia. Question 37. A Category 3 tracing persists despite intrauterine resuscitation measures. What is the nurse's priority? A. Continue monitoring. B. Prepare for immediate operative delivery. C. Encourage pushing. D. Decrease IV fluids. Answer: B. Prepare for immediate operative delivery. Rationale: Category 3, absent variability with recurrent decels or bradycardia, indicates fetal hypoxia or acidosis. Immediate delivery prevents neurologic injury. Question 38. Rh-negative mother did not receive Rho-D immune globulin after previous delivery and is now pregnant. Indirect Coombs test is positive. What does this indicate? A. Sensitization has occurred. B. No risk exists. C. Newborn will not be affected. D. Rho-D immune globulin will reverse antibodies. Answer: A. Sensitization has occurred. Rationale: positive indirect Coombs means maternal antibodies are already formed. Rho-D immune globulin prevents sensitization but cannot reverse it. Fetus is at risk for hemolytic disease. Question 39. True or false? Meconium-stained fluid with a vigorous newborn requires routine suctioning before stimulation. True, false. Answer: B. False. Rationale: current guidelines recommend routine care for vigorous infants. Suctioning is only indicated for non-vigorous newborns with poor tone or respirations. Question 40. 2 hours after cesarean birth, a client develops abdominal distension, decreased urine output, falling hematocrit, and stable fundus. What is the most likely cause? A. Uterine atony. B. Internal surgical hemorrhage. C. Bladder infection. D. Normal recovery. Answer: B. Internal surgical hemorrhage. Rationale: stable fundus rules out atony. Decreasing hematocrit and oliguria suggest internal bleeding and hypovolemia. Immediate surgical evaluation is required. Delay risks shock and organ failure. If these questions made you think harder than usual, good, because NCLEX 2026 is no longer testing memorization. It's testing: can you recognize deterioration early? Can you prioritize under pressure? Can you save 2 lives at once? If you want 15 ICU-level obstetric shock and DIC questions next, comment ICU OB. Subscribe for more advanced clinical judgment breakdowns. And remember, in maternal nursing, you are caring for 2 patients, but you always stabilize the mother first.